Namaskar and a very warm welcome to this edition of our program Let's Talk Health. You're watching India Science. Well, India's cumulative COVID 19 vaccination coverage exceeds 192 crores, and new COVID cases that have been reported in India are 2,226. More than 8.8 lakh vaccine doses administered in the last 24 hours, and the recovery rate is at 98.75%. Well, friends, as COVID 19 continues to surge in the country, COVID related queries are on the go. People are speculating about booster doses and its effects as well. In this program, where we take your questions from Facebook and YouTube Live, today we're joined by the very well known Dr. Meenu Walia. Professor Meenu Walia, Senior Director and HOD Medical Oncology and Hematology, Max Super Speciality Hospitals, Vaishali, Patparganj, and Noida. Many thanks for joining us today and namaste.
Hi, namaste, namaste.
Thank you so much, ma'am. My first question to you would be to tell our viewers about the current cancer scenario in India in view of the new variants and the new COVID 19 strains. How do you kind of prioritize cancer management?
Uh,
Are there any specific protocols?
unfortunately, unfortunately, I'll say the current scenario of cancer in our country is not very good. The cancer incidence seems to be rising day on day and year on year. And there have been lot many more cancer cases in the present day than what we used to see a few years back. And the incidence seems to be further increasing. According to a recent study that was published last year in December 2021, there seems to be approximately 13 lakh cases of cancer in our country. And plus, we expect that this incidence is further going to increase in the coming years. And COVID also has a lot to do with the way cancer was being managed, because cancer patients generally require continuity of treatment, and with COVID, with not many patients coming out of their houses to receive cancer treatment, we we faced a lot of problems too.
Yes, ma'am. Any specific protocol that your hospital is following since you're taking care of quite a few hospitals, ma'am? Or is it as usual?
Yes, there were protocols initially that were being followed in our hospital. We would have COVID testing for the patients at baseline, COVID precautions, and also advise vaccination at appropriate intervals for all the patients. Now that many of the patients are now vaccinated, some have already had COVID, probably things are much more smoother now. And now in our country, I feel we have all learned also how to live with COVID, and plus our cancer patients and cancer specialists have also learned how to live with cancer and COVID both. So that is both being managed simultaneously.
All right, ma'am. Could you please tell us what are the common cancers that we get to see in India? How many types of cancers, if you could broadly specify?
So there happens to be more than 200 different types of cancer. So whenever we talk of cancer, we need to remember that cancer is not one disease. There are more than 200 different types of cancers which are prevalent and which can be seen in different parts of the country, or rather in different parts of the world. When it comes to our own country, the common cancers that we see in our country is generally head and neck cancers, that is cancers of the oral cavity, lung cancer, among the women, breast cancer, GI cancers. So these are the common cancers that we see in our country, and also cervical cancer, cancer of the cervix among our Indian women.
May I ask you to elaborate on GI cancer, ma'am, and cervical cancer? What exactly is this, and
So when we talk
what are
about
the symptoms?
uh, when we talk when we talk about GI cancers, we are basically talking about cancers of the food pipe, cancers of the stomach, cancer of the intestines, that will include colon, rectum, and anus. So these are the generally the GI cancers that we see in our country, out of which Both stomach cancers seems to be quite common and also colorectal cancers, that is cancer of the large intestines, which is very common in our country.
And what kind of treatment is given for GI cancer, and what kind of screening is done for this particular kind of cancer? We have a question, ma'am.
So, what is the type of treatment that is given for GI cancer will depend on which part of the gastrointestinal tract the cancer is coming from. Also, there will be various other factors like what is the biopsy, what is the type of tumor that we have, whether it is squamous cell carcinoma or it is adenocarcinoma. These are the histopathological characteristics. And plus also, what is the stage of this cancer? So treatment depends on various factors. For example, if it is the cancer of the upper part of the food pipe, that is upper part of the esophagus, and it is still limited to the esophagus and it has not spread in the body, then the common treatment that we give in these kind of cases is radiation plus chemotherapy. In a lower part of the esophagus, depending on whether it is squamous and adeno, the treatment may change. Surgery may also be a part of the treatment, and the sequential, the way we approach the treatment is also different in this group of patients. Similarly, I mean, what I want to say is every part, like colorectal cancer, will be treated in a different fashion. Stomach cancer will be treated in a different fashion. Also, the different type of cancers. For example, in stomach, sometimes we can have lymphoma or we can have an adenocarcinoma. If we have lymphoma of the stomach, then the treatment is entirely different. Then the treatment is chemotherapy alone. If it is an adenocarcinoma, then it depends on which stage of cancer, whether we have to go for surgery first or we have to go for chemo first. So there are a lot of permutations and combinations that is required in cancer patients in today's state. And depending on the stage, depending on the type, depending on the different site where the cancer is, the best permutation combination for a particular patient will be decided, and that is what is offered to the patient.
Yes, ma'am. We have a YouTube question now. This comes to us from Dolly from Noida, and she wants to know what is interferon therapy and how does it kind of help?
Intra-peritoneal therapy, is it that what I heard?
Yes, ma'am. Yes,
Is it
ma'am.
that what you are asking?
Absolutely.
So yes, so I will rather say a very interesting question, Dolly. Intraperitoneal chemotherapy is a type of therapy that is given for abdominal cancers which have a tendency to spread in the peritoneum. So what is peritoneum? Peritoneum is a lining. It is a lining of the various abdominal organs. It is a lining in our abdomen. So what happens in some of the cases in abdominal tumors, the disease is studied in the peritoneum, and when we give chemotherapy later on after surgery, there is a possibility that because of post-operative scarring, post-operative fibrosis, the chemotherapy, the chemo agents may not reach the site of the disease to that much effect in that much effective manner. So many times in some of the cancers, whichever peritoneal spread, it is sometimes advocated that when you are doing surgery, at the time of surgery, you do what is known as HIPEC. HIPEC stands for hyperthermic intraperitoneal chemotherapy. That is, at the time of surgery, when the abdomen is still open, you give chemotherapy then and there, that is directly into the site in the abdomen. And this chemotherapy is generally given, why we say hyperthermic. It is given, it is at a higher temperature than the usual temperature, because this high temperature you cannot give when you give chemotherapy through the IV route. So you give within the peritoneum, and when this heated chemotherapeutic agents are given, then it is believed that the absorption of these chemotherapeutic agents is much better in the peritoneum, as well as it is directly acting on the cells where the disease is. So the efficacy may be slightly better. So that is what hyperthermic intraperitoneal chemotherapy is all about. And in today's state, it is being done in various kind of abdominal cancers like recurrent ovarian cancer or primary peritoneal carcinoma or even colorectal cancers with multiple recurrences. So this is being done in some of the centers of our country.
She's added one more question to this, and she wants to know whether it is cost effective or pocket friendly, and is it done in government hospitals as well, ma'am?
She asked is whether it is cost effective, and the second part of the question is.
Whether it is pocket friendly. Is it done in government hospitals? That's what she's just sent back.
So this is a highly, I will say, technologically advanced procedure, and it requires lot of expertise, and the expertise is not only in the infrastructure. First of all, not every hospital will have a HIPEC machine. There is a special machine for HIPEC that has to be required. And then it also requires expertise of the treating team. So the surgeon who is going to do the HIPEC surgery has to be an expert in that. Needs to require a special expertise. The anesthesia team, because whenever we do HIPEC, the total duration of the surgery increases. So once the duration of the surgery increases, you expect some more complications may happen. So anesthesia team should also be highly trained for this kind of a procedure. Whereas it also requires a trained medical oncology team who is used to doing these kind of procedures. So it is an expertise which it requires a good infrastructure. It requires an expert team of doctors from all the specialities. Plus, the post-operative care of this patient will also be slightly more and much more prolonged. So there has to be expertise required at all the steps, and that is why the cost of this will be much more than a normal surgery. And then whether it is cost effective, so it depends on what particular indication. So if it is an upfront ovarian cancer, we normally do not ask for HIPEC. But if it is a in a recurrent setting, and if it is only a primary peritoneal disease, if the disease is not only primary peritoneal and the disease is more in the liver, the disease is in organs also, then possibly HIPEC will not give you that much optimum results. So there's something called a scoring. Before one does the surgery, one needs to assess that what will be the success rate of HIPEC, and even at the time of surgery, when they do the cytoreductive surgery, sometimes they feel there's not enough, not a complete clearance has been done. There's still significant residual disease. In those cases, if it is significant residual disease, probably HIPEC will not be that effective. So that call will be taken, the final call is taken in the OT with the operating team, even before surgery and after this thing. And that is, so there are a lot of ifs and buts in the right setting. Upfront, we normally do not advise HIPEC. If it is a primary peritoneal disease, recurrent disease, mainly in the peritoneum, not anywhere else. Suppose the patient has a lot of disease in the lungs also, or the disease in the liver also. Even if we do HIPEC, probably we will not be attaining the same results, because with HIPEC, you are only addressing the peritoneal disease. You are not addressing the liver parenchymal disease or the lung disease. So these are the things which needs to be discussed with your treating team, the medical, the surgical, and the entire team, and the pros and cons can be discussed. So the last question you asked is whether it is available in government hospitals. Yes, it might be available in a government hospital. You will have to inquire about it. But again, it requires expertise, infrastructure-wise, and the team, and lot of these procedures should have been done. As far as I know, it is available at very few centers all over the country. I mean, only I guess probably there, if we can count on our fingers, 6 or 7 centers in India which are able to offer HIPEC to the patients.
Yes, ma'am. Now the next question is, please tell our viewers about the common symptoms of oral malignancies and how this one get to know that we need to get the screening done early.
So I think there are two different questions to it. One is
Yes.
that how do we come to know that whether we need to do screening done? And second is what are the common symptoms of oral malignancy? I will take the second question first. How do we come to know that we need to get the screening done? So there's nothing that we come to know that we need to do the screening done. Screening means testing for cancer. Screening is testing for a disease when there is no sign and symptom of the disease. Screening means testing for a disease when you are absolutely healthy. So screening needs to be done irrespective. we expect at the time when we are doing screening, you do not have any sign and symptom of disease. So screening is generally advocated depending for different countries, depending on the disease rate that you have. For example, if screening for cancers should be done for all the cancers, breast cancer, even when the lady does not feel any lump in the breast, we say screening for breast cancer should be done 40, the mammography should be done 40 years onwards. Similarly, because head and neck cancer is at so much high incidence in our country, so one needs to screen head and neck cancer, and then screening of head and neck cancer is very simple. That is a simple oral evaluation. It doesn't require too many tests. So screening, when it comes to any cancer, screening should always be done, because with screening, we want to detect cancer early, and screening should be done in an asymptomatic population. It should be a part of your annual health, what do you say, a
Periodic
preventive health
checkup.
checkup. So screening should be a part of that only. And your first question was, what are the signs and symptoms of head and neck cancer? So signs and symptoms of head and neck cancer can be depending on which part of head and neck it can be. So head and neck will have different components. There is a tongue, there are cheeks, there is the, what you say, the alveolus, that is the jaw bones, upper and lower margin. So mouth cancers can present with an ulcer. It can present with an ulcerative lesion in the tongue. It can present with the growth anywhere in the mouth. There can be growth in the jawbone, or there is a growth in the buccal mucosa, or what we say, an ulcerated growth. There is an ulcerated lesion. The most common presentation is there is soreness. There is an ulcer, there is a soreness, and there is a growth. Anywhere in the mouth can become an early sign of head and neck cancers. Some cases can present, even in head and neck cancers, can present with some growth in their neck. So if there is a lymph node in the neck, some growth in the neck, that can also be a sign of head and neck cancers. Difficulty in swallowing. So if there is cancer of the tongue or cancer of base of the tongue, so the person can find that even they find difficulty in eating, difficulty in swallowing, and in some cases, the swelling can become painful also, and there can be some change of voice also. So these are all the signs and symptoms of head and neck cancers.
Absolutely. Neha Dubey is flashing a question again and again, and I think we'll take that question. She says, at what age do you think she could perhaps go in for a mammogram checkup?
So when it comes to screening, we say, when should breast screening start? And the second is, at what age should mammography start? What we have to understand is, whenever we talk of screening for breast cancer, there are three components of screening for breast cancer. One is a breast self-examination. Second is a clinical breast examination. And third is mammography. And what is mammography? It is a simple X-ray of the breast. Breast self-examination should start as early as 20 years of age. Rather, as early as the girl is adult, she understands what this breast self-examination is about. She should be taught to do a monthly breast self-examination done. 30 and above, we say a clinical breast examination that should be done by a healthcare provider, whether it is a doctor or a nurse or somebody trained in doing a breast examination, that is by a health professional, it should be done. Mammography, which is X-ray of the breast, the general recommendation for getting a screening mammography is generally 40 years and above. So there, between different countries, it varies. 40 and 50, 40 to 50 is something which is recommended most often. In our country, we say 40 and above, every lady should have a mammogram, an annual mammogram done once in a year.
Yes, doctor. The next question that is coming to us, and this question asked for mammograms was again asked by Nisha from Dehradun, and she's asking us one more. But before that, let me take this question. What is hormone therapy for cancer? Is it new? Tell us about photodynamic therapy and immunotherapy and how they are different, doctor.
Can you come up with the question again? There was some break in the voice. I could not understand. Did you talk about hormone therapy, or you were talking about?
One was hormone therapy, and then there are two more therapies that they have asked. One is photodynamic therapy, and the other is immunotherapy.
Yes. So, hormone therapy is a type of therapy which is given for certain cancers which are hormone dependent cancers. So, what are those cancers in our body which are hormone dependent cancers? For example, breast cancer. Breast cancer is a hormone dependent, maybe not all breast cancers, but some of the breast cancers can be a hormone dependent cancer. Some of the uterine cancers can be hormone dependent cancer. Some of the ovarian cancers can be hormone dependent cancer. Similarly, in males, prostate cancers can be hormone dependent cancers. So these are few cancers which are hormone dependent cancers. In these cases, one can give hormonal therapy, and hormonal therapy benefits these group of patients. For example, if it is a hormone dependent, hormone positive, we do testing of, in all breast cancer cases, we do testing of two specific receptors, which is estrogen receptor and progesterone receptor. So if testing of this estrogen and progesterone receptor is positive, then these are the patients who will benefit from hormonal therapy. Most hormonal therapy are in the form of tablets, which will act on these receptors. Yes, in some cases, the hormonal therapy can also be in the form of injections also. So this is what hormonal therapy is there. So hormonal therapy is generally considered much more friendly to the patient compared to chemotherapy. It has much less side effects. In most cases, hormonal therapy, wherever there is a hormone dependent tumor, is generally given for a much more longer time compared to the other therapies. That's it. So the other thing you wanted to know is photodynamic therapy. So photodynamic therapy is also, it is a type of cancer treatment which applies with use of photosynthesizers to create some reactive oxygen species, and then they try to destroy cancer cells. So yes, photodynamic therapy is also one of the advocated therapy, but its role is very, very limited. In my so many years of oncology career, I would have seen the role limited to a subset of less than a fraction, a minuscule of patients, because it will be indicated only in a very, very early disease, or it is indicated as a palliative thing in a disease which is incurable, and you want to give only probably to control the some kind of giving some kind of a palliative response. So that is what photodynamic therapy is about. And the third very important thing which you asked about is immunotherapy. Now, immunotherapy, I would say, is something which is creating a lot of breaking news among the oncology circles, in the fact, in the sense that 2 years back, even the Nobel Prize for medicine also
Mm.
was to a gentleman for immunotherapy in oncology. So immunotherapy is something which we have been using in oncology for a very, very long time. But now we are using in a very different fashion. There are a lot of monoclonal antibodies, a lot of new different kind of medicines which are available, and which basically how it works is it mm, it basically uh, increases the body's own immune response to cancer cells, or unmask the hidden cancer cells to the immune processes of the body. So we have various agents like nivolumab, pembrolizumab. So various molecules are now available which are part of immunotherapy. And in certain cancers where chemotherapy did not do so well, immunotherapy seems to be giving very good responses. The immunotherapy is, yes, is new thing, and that is also what we have now started. For example, in lung cancer, in malignant melanoma, in renal cell carcinoma, in these kind of malignancies, there's a lot of role of these new immuno-oncological agents also.
Right, ma'am. The next question is, how can targeted therapy be used, if at all, to arrest the cancerous cells? Does it help? What is it? If you could please frame the answer and tell us again.
So targeted therapy is also, I'm glad the audience seems to be very highly educated and
And
seems to
lots
have
of questions flashing.
known the latest what is happening in. So, targeted therapy is also one of the treatment options for cancer treatment. And targeted therapy comes in various different ways. What is important is we need to know the target. When you talk about targeted therapy, you're talking of one particular target and you are trying to attack that particular cell. Okay, so in certain cancers, in today's date, you know what is the abnormality at the genetic level. So once you know that this is an abnormality, you can give certain molecules that will specifically target that abnormality only and prevent the cancer cells to replicate. So this is what is targeted therapy, and it is found actually done a lot of wonders in the new medical oncology, in the new field of oncology. For example, there is one cancer, there was one of the blood cancers, which is chronic myeloid leukemia. Few years back, the only treatment for chronic myeloid leukemia used to be stem cell transplant or bone marrow transplant. So later, when it was recognized, what is the basic abnormality in chronic myeloid leukemia is a mutation. There is a mutation which is known as BCR-ABL mutation. This happens because of the translocation of two chromosomes, because of certain genetic this kind of a problem. Because of this mutation, the cells have uncontrolled growth, and chronic myeloid leukemia happens. And this is the mutation which is responsible for the disease and progression of the disease. So once you know that this is a mutation, so a targeted medicine could be developed targeting this mutation, and it will prevent the BCR-ABL, the genomic configuration to work, to prevent, and it will prevent it prevents this molecule to get activated, and with this you can actually control the cancer. And in today's date, we see so many of these patients of chronic myeloid leukemia being cured on oral tablets alone. So they have been using just oral tablets for years altogether and having long survival, and not many of them require bone marrow transplant. So this is how targeted therapy has also changed the scenario in few particular cancers. Even in breast cancer, we now know there are various targets. There are targets like HER2/neu, which is a new receptor that we know in breast cancer. When you give targeted therapy that addresses this receptor, again, you have a lot of new targeted agents, and then results of these patients are much better. In few kind of lung cancers also, you can find certain mutations. When you give targeted therapy to that particular mutation, these are the patients who will probably not require chemo or may not do that well with chemotherapy, and they will do much better with the targeted therapy. So targeted therapy is one of the newer advances of precision medicine, and it is something that if every cancer should ideally be tested for a target mutation, and if some target is found, then targeted therapy definitely benefits these kind of patients if we have an actionable target.
Yes, ma'am. We have a YouTube question now. Dushyant from Aligarh, and he wishes to know about the side effects of chemotherapy because his mother is going in for.
So side effects of chemotherapy, basically we have to understand is how does chemotherapy kill cancer cells. Chemotherapy has no way to distinguish between a normal cell and a cancer cell. The only criteria that it kills cancer cells is any cell which is rapidly dividing. So it acts on particular phase of the cells. So if it is like, for example, in a cell cycle, you have different phases. You have G0 phase, G1, S phase, and then G2 phase, mitotic phase. So there are different phases of the cell cycle. So different chemotherapeutic agents work on different phases of the cell cycle. So any cell which is actively replicating, so the chemotherapy will kill those cells. And in the same process, because it cannot distinguish between a cancer cell and a normal cell, sometimes the normal cells also, which are actively replicating in that particular phase of cell, will also be affected by chemotherapy. So these becomes the side effects of chemotherapy. For example, with chemotherapy, you very frequently you may find that there may be some drop in WBC count, some drop in hemoglobin. You can have some oral ulcers, loss of taste alterations, because this all is related to again the oral mucosa, the GI mucosa, which again rapidly replicates. So it can affect these things. So one can have GIT related side effects like nausea, vomiting, alteration of bowel habits, some change of bowel habits, loose motions, diarrhea. Then similarly, there can be organ-specific side effects. For example, the counts may go down, the hemoglobin may go down. Some chemotherapeutic agents can also affect the platelets, although these are temporary side effects. Chemotherapy can also affect hair. So many chemotherapeutic agents will lead to hair loss. So these are something which is one of I will say the most worrisome effect for most of our female patients. Then these are the common side effects that we see with chemotherapeutic. Some chemotherapeutic agents may cause some drop in ejection fraction, may affect your heart. So there are different chemotherapeutic agents, and different chemotherapeutic agents will affect the body differently. And that is why we do frequently do some baseline tests, and accordingly there is a maximum dose which is advocated of different agents. And apart from that, whenever we are giving chemotherapy in a younger population, in young females, in young boys, unmarried females and boys, we are also concerned about some infertility effect. Some chances of decreased, like the chances of conceiving may be decreased because of these chemotherapeutic agents. So these are also something which bother us whenever chemotherapy is being given in the younger population.
Absolutely, doctor. And we'd like to continue this conversation in part two because we're absolutely out of time, and due to paucity of time, in the end, I'd like to thank you, Dr. Meenu Walia, for joining us and sparing your valuable time in educating us and in telling us how we could perhaps prevent cancers. And with that, friends, this is the wrap of this edition. We'll be back with more interesting episodes on question hour. Till then, get vaccinated, stay safe, stay masked. That's the only way. Mask up, India. On that note, namaskar. Many thanks for watching. Keep watching India.